Should we start? Vikram?
जी सर, बस इकरा स्टार्ट कर रहा है, जस्ट अ मिनट।
Assalamu alaikum. Do you hear me? Assalamu alaikum. सर मेरी आवाज आ रही है?
बेटा आ रही है तुम्हारी आवाज?
हेलो,
आवाज आ रही है तुम्हारी?
अस्सलाम वालेकुम सर।
वालेकुम सलाम।
Hello, excuse me. I welcome you all on our preterm nutritional issues. Today we are going to talk about the post-discharge nutritional issues in preterm infants by our worthy Professor Syed Rehan Ali. Sir has done MBBS from Sindh Medical College in 1993. Then sir got post-graduation in neonatology from UK and Ireland. And sir has the extensive experience of 20 years in neonatology. And sir has worked in Khan for since 8 years, from 2009 to 2017. And from 2017, sir is working as in charge of neonatology unit here in Indus Hospital. So, Sir Rehan, sir, over to you. Thank you.
Okay, thank you very much, Ikrar. So I think this is the fourth of the module or the series of preterm nutrition. I'm going to talk about post-discharge nutritional issues. And I hope everyone is hearing me all right. And you have to excuse me about the quality of my voice because I've been slightly under the weather and having slight flu as well. So when we are talking about post-discharge nutritional issues in preterm infants, our learning objective of this talk would be to discuss discharge planning, discuss post-discharge nutrition requirement, how to avoid post-discharge growth faltering, and in the end, we're going to discuss about relevance of optimal complementary feeding. So one thing is for sure that in infant who are not recovering and there is no sign of systemic illness, protein status should be closely evaluated and supplementation should be instituted. When we're talking about discharge planning of preterm infants, we also notice that there is a growth faltering which is common during the hospital stay and also at discharge. Again, Dusick et al. In 2003 have clearly mentioned that 89% of preterm babies who've been discharged from NICU, they have a weight less than 10 percentile at discharge. And if we combine that with the length and the head circumference, then this figure comes to around 40% overall at a corrected gestation. Now, about the head size and the brain development. As you can see, from 25 weeks onward until term, you can see the difference in the overall smoothness, which again, as the gestation goes on, again, you can see this clear sulci-gyrate differentiation at term. So brain volume is a direct circumference, and we need a program growth velocity. We all know that it is greatest in preterm, approximately around, at term. So higher the head circumference, associated with higher brain volume. And we all know that at 2 years of age, microcephaly, which is the head circumference less than 2 standard deviation, is associated with poor neurodevelopmental outcomes. Now, if you talk about the mental developmental index,
सर
Yes.
स्लाइड शेयर नहीं हो रही है, वो सॉरी स्क्रीन मूव नहीं हो रही है, तो इसको जो ना अनशेयर करके वो स्टॉप शेयर करके दोबारा शेयर करें.
बेटा स्क्रीन तो मैं चेंज कर रहा हूँ, हो रही है चेंज कि नहीं?
लेकिन सामने नहीं हो रही. इसको स्टॉप शेयर करके
अच्छा.
दोबारा शेयर करें या स्लाइड शो करें दोबारा.
दोबारा शेयर करें. अब देखो.
जी अब वो हो रही है, ठीक है.
अब हो रही है.
अब चेंज करें, स्लाइड चेंज करके एक मतलब करेंगे.
नहीं, स्लाइड चेंज नहीं हो रही. It's not happening.
स्टॉप शेयर
अब
करके
देखो.
दोबारा करें. नहीं, स्लाइड चेंज नहीं हो रही है.
अब देखो. अब अभी
जी
भी
अब
नहीं
हो
हो
रही
रही
है.
है.
अब हो रही है.
अब हो रही है. ठीक है. So we're going to continue. So in terms of head size and brain growth, we also know that there is a lower MDI and psychomotor developmental index directly associated with the amount of brain volume and the head circumference. Next slide. So the aim of nutrition, again, is related to two major aspects, which is the support and the development, and the second objective should be to prevent the nutritional deficiencies. Now, when we are talking about support and growth development, it's basically we are trying to prevent the growth retardation. And in terms of preventing nutritional deficiencies, like anemia, poor neurodevelopmental outcome, and undermineralized bone. So this is the basic aim of the nutrition for any preterm post-discharge probably should be. Now, when we are looking at the readiness, when the baby can be discharged home, the baby should be medically stable and should be physiologically mature. Now, in terms of the aspects, what do we mean by medically stable and physiologically mature baby? That the baby has to have a normal body temperature, should be feeding successfully, baby should have apnea-free period, should be showing the signs of sustained weight gain, and oxygen saturation maintenance from 90 to 95 in room air. Now, pre-discharge monitoring, we do some assessment and screening, try and do appropriate investigation needed, possible immunization, whatever needed before discharge, a complete thorough physical examination, screening for ROP and hearing screen, cranial imaging, and if possible, RSV prophylaxis, which is again not available in our part of the world. Now, assessing growth at discharge, assessment of growth and nutrition status post-discharge in premature infant. I mean, this is just to give you an idea that in terms of weight, length, and head circumference, what should we try and achieve from 0 to 3 months There should be a sustained weight gain of 20 to 30 grams per day. Length should be 0.7 to 0.8 centimeter per week, and head circumference is around 0.4 centimeter per week. And nowadays we have intergrowth 21st charts, which are commonly used for growth monitoring in very low birth weight preterm infants. Now, what advice would we give to the mother at discharge? There are many aspects of when we are discharging the baby. Basic infant care, asking mother for a supine sleep position. We also give feeding instruction and proper storage, dosage, timing, and administration of medication. Also, the advice at discharge, again, we explain the mother about the importance of infection control, training on oxygen administration, tube feeding, how to do the CPR, all the devices, support devices we are discharging the baby on, how to operate those, and how to measure it. And last but not least, we explain the danger signs as well. Now, there are some red flags in terms of growth, clinical, and feeding wise. When we are looking at the growth, the red flags would be if there is a weight loss or an excessive weight gain, or a poor rate of weight gain. As I said, 20 to 30. Again, in preterms, they should be around 15 to 20 grams per day. Clinically, you should also look at the persistent spit-ups, refusal to eat. If the baby is not passing bowel for 3 days, evaluate the baby. Feeding-wise, red flags would be if there is a reduced duration and frequency of the feed, decreased volume of the feed, if the baby is fussy, or if there is a distress infant. These all red flags should prompt the parents to go and see the doctors. Now, in terms of post-discharge nutrition requirement for preterm infants, now there are many feeding instabilities. Many things can happen when we are, and many reasons which interferes post-discharge, like if the baby is in unstable state, if there is a physiology, limited endurance in terms of, baby has a poor suck, swallow, breathe coordination is not there, if there is an impaired swallowing mechanism, and if there is a poor oral motor control and coordination. These are all aspects which we need to discuss post-discharge. Now, there are key risks and morbidities which is also associated with prematurity, which we need to keep an eye on when we are discharging the baby. In terms of, starting from hernia, bronchopulmonary dysplasia, thinking about neurodevelopmental consequences, explain mother about the SIDS, apnea and bradycardia, explain about the gastroesophageal reflex, cryptorchidism, RSV prophylaxis, if there is a post-hemorrhagic ventriculomegaly. So these are all the risks associated with what we should keep in mind when we are discharging with these morbidities. Now there is a key frequently identified morbidity in infant. There is a paper published by Nargis et al. In 2013. We don't have a lot of papers from our side of the world, but the frequently identified morbidities in preterm infants, jaundice, respiratory morbidities, and hypoglycemia. But again, not to forget what I mentioned before, all these morbidities, we should keep that in mind. Now, what is the critical window? It's catch-up growth. We all know that in many preterms, if not all, very low birth weight infants are growth restricted at hospital discharge, and several factors contributes. When we're talking about this critical window, there is a very narrow window linked to those growth restricted infants, and the critical period may the first year with respect to the development of head circumference, and first 3 years with respect to the height. There is a probable association of slow growth rate associated with early introduction of cow milk or earlier weaning. And I have mentioned some references below in terms of growth outcome in feeding practices and very low birth weight infant less than 50 and 100 gram. And they have shown that there is an association of slower growth rate if there is an early introduction of cow's milk, or if the baby is started earlier weaning. So what are the findings in terms of growth? We know that the 2/3 of infants are underweight and stunted. Nearly 50% shows microcephaly at 1 year. And in terms of extremely low birth weight, they showed retarded growth at 1 to 2 years of age. Now, what would be the post-discharge nutrition and how can we avoid growth faltering? Now, what is the recommended feeding progression? What we usually do is that 0 to 4 months, breast milk as a primary source of nutrition. Again, 4 to 6 months, the infant shows signs of readiness for solid feeds. And it all depends on the corrected gestation of the baby and how ready the baby is. Again, as I said, breast milk should be the primary source of nutrition. Now, the introduction of complementary food based on the developmental stage and the baby's feeding skills. If we are achieving that, then we should go ahead. Now, in terms of recommended, second. So in terms of recommendation of feeding progression in preterm infant, at 2 months, exclusive breastfeeding on demand. If breast milk, donor milk is not available, then we can also think of using a premature formula. Up till 6 months, breastfeeding should be continued. And there is a recommendation that iron supplementation, 2 milligram elemental iron per kg per day, with a maximum dose of 15 milligram iron per day, should be appropriate for growth in these babies. Again, at 6 months, appropriate complementary feeding when the baby is ready to feed. So breastfeeding is the only post-discharge nutrition. There are concerns that it may not meet the nutritional requirement. The difference is the mature milk of a term mother and the premature milk of the preterm mother might not fulfill the nutrition requirement of these babies. So post-discharge infant on breast milk directly, their growth rate should be monitored carefully within 48 hours and thereafter reevaluated in a week's time to make sure that the baby is growing and gaining weight. And there might be a role of fortification which needed for monitoring. Breastfeeding as post-discharge nutrition. We all know that there are short-term benefits like decreased rate of late onset sepsis, necrotizing enterocolitis, retinopathy of prematurity, and fewer rehospitalization in the first year of life. And in terms of long-term benefits, there are lower rate of metabolic syndrome, improved neurodevelopmental outcomes, lower level of blood pressure, high blood pressure, and low density lipoprotein, and less insulin and leptin resistance. So when there is a need for human milk fortifier in preterm formula, I mean, nutrients in breast milk, as I said, may not be insufficient to meet the higher requirement of a preterm baby. For that, human milk can be fortified with human milk fortifier, or a preterm formula can be used if human milk is unavailable, donor or human milk is unavailable, or it is insufficient to meet the requirement, higher requirement of the preterm baby. Now, as far as fortification versus no fortification, there's a Cochrane review with multi-nutrient fortification versus no fortification of human milk. And it shows, it compares between the two groups, very low birth weight on fortified versus non-fortified breast milk. And they have found no difference in growth outcome between the two groups. And there is no difference in neurodevelopmental outcome in the two groups. So again, we still know little about human milk fortification. As the time moves on, again, there is no fit criteria which we can follow. Again, you have to follow the preterm and see what are his nutrition requirements. Now, the possible benefit of fortification with human milk fortifier for preterm infant, again, there's an improved weight gain, there's an increased linear growth, also increased bone mineralization. It improves the protein status and normalization of serum calcium, phosphate, and alkaline phosphatase. In terms of fortification of breast milk, there is evidence study done by Connor et al., which added the multi-nutrient fortifier to human milk each day for 12 weeks to preterm infant after hospital discharge, addresses the nutrition deficits and shows improved growth. Again, a study from McCormick et al., which shows a feeding preterm infant multi-nutrient fortified breast milk increases the growth rate during infancy. So monitoring of feed at home, human milk fortification then again depends on the infant nutritional and biochemical status. So if the infant has limited breastfeeding ability, then we can fortify alternate methods like cup and spoon, orogastric or nasogastric, etc. And if the infant is breastfeeding well and the mother has a good milk supply, then we should try and minimize fortification of express mother milk and try and increase the concentration of express mother milk to maximize nutrition. Now, express mother milk can be fortified to 24, 27, and 30 kilocalories per ounce, but that again depends on the mixing human milk fortifier with the mother milk. The only human milk fortifier we use over here is a Nestle one, I think, and it cannot support because it's not the liquid form, it's the powdered form. And if we start doing that, like increasing the calories, then we probably would lose a lot of human milk fortifier, which is expensive too in this part of the world. Now, feeding option for post-discharge period, there is human milk, there is fortified human milk, there is preterm formula, and there is standard term formula. Now, the difference between various infant formula for post-discharge period. Now, we all know that the standard term formula, I mean, when given to the premature infant, they don't have the amount of high energy or the proteins which the newborn require. And this slide is just showing the differences between the standard term formula and high energy formula, like 100 kilocalories per 100 ml. Now the need, what is the need for post-discharge formula? So at the time of discharge, we try and prevent the nutrient deficit as much as possible. And when we are discharging the preterm infant, we should choose an appropriate method of feeding, which provides higher nutrient requirement to these babies. Now, the fundamental principle underlying nutritional support is that intake meets the need, thereby ensuring the best outcome. So the clinical evidence with the improved growth in terms of preterm than the standard formula, again, the preterm infants, Caregivers et al. Shows that the preterm formula 22 kilocalories per ounce and the term 20 kilocalories. At 12 months of corrected age, there's a difference between the two in terms of weight, length, and head circumference. I mean, to me, it's not a huge difference, but it does show a difference between these two. Again, in terms of preterm formulas, they're showing that post-discharge, it shows improved catch-up growth, increase in weight, height, and head circumference, and increase in bone mineralization. In terms of supplementation of vitamins and minerals, preterm infant have lower nutrient store, and breast milk does not have enough vitamin A to support their needs. So in terms of vitamin A, we know that it helps in cell differentiation, provides immunity, and it also helps in ocular and respiratory development. And its deficiency leads to increased risk of lung diseases. So the recommendation is around 5,000 international units per day for the first month of life, leading to 300 international units per day until 6 months of age. Now, in terms of vitamin D, again, the functions would be to support bone mineralization and neuromuscular function and improve calcium absorption. And if it is not present sufficiently in the milk provided to the preterm baby, then the deficiency leads to osteopenia of prematurity. In terms of recommendation for the dose, it varies from 200 to 1000 international unit per day to 800 to 1000 international unit per day until 12 months of age, and around 280 to 340 international unit per day after 1 year till 5 years of age. In terms of iron, which is essential for the neurodevelopment and whose deficiency will lead to irreversible long-term developmental impairment, altered immunity, temperature instability, and the recommendation from ABSCON would be around 2 to 3 milligram per kg per day of iron at around between 2 and 6 weeks until 6 to 12 months of age, depending on the diet babies taking. Now, when we are talking about the recommendation, the monitoring should be aimed at to assess the rate of weight gain, head circumference and length, looking at osteopenia, hypophosphatemia, elevated alkaline phosphatase, decreased bone mineral content, and to check hemoglobin as a risk of iron deficiency. Again, the iron deficiency, as I said, related to the better neurodevelopment, and the concerns has been expressed about the catch-up growth and the development of, not to forget the development of insulin resistance and metabolic syndrome, leading to the idea that that bigger might not always be better, even in preterm infants. Again, there is some confusion exists when there's a term we use catch-up growth. Rather than using catch-up growth in describing these preterm babies, I think the better term should be a catch-back growth, which reflects the growth of that preterm baby. If that preterm or the mother would have to continue until term, how would this baby would grow? So I would rather use the terminology catch-back growth. Now the recommendation for practices of post-discharge. Now ABSCON recommend for appropriate weight for post-conceptual age, again breastfeeding if possible, or standard formula with long-chain fatty acid, and ABSCON recommendation for normal weight if the baby is not gaining human milk fortification, or if formula fed a special preterm formula with high contents of macro and micronutrients. So my key messages would be feeding concern in preterm infants during post-discharge phase include limited endurance, poor suck, swallow, and breathe coordination, impaired swallowing mechanism, and poor oral motor control and coordination. The aim of nutrition post-discharge are to protect against nutritional deficiencies and to support growth and development. Slower growth rate, bone mineralization, nutrient deficit, and the risk of osteopenia are some of the nutritional concerns of feeding breast milk to these preterm babies. And APSCAN recommends supplementation with human milk fortifiers for breast milk or formula milk for infant discharge with a subnormal weight for post-conception age. I would conclude that the preterm, particularly breastfed, very low birth weight infants are likely to be undergrown at hospital discharge and therefore are at increased risk of poor growth after hospital discharge. Because poor growth is associated with poor neurodevelopment, and it is recommended that they are fed either breast milk, if available, or other options like human milk fortifier or high calorie protein formula, irrespective of how the infant is fed. Growth must be closely monitored, which probably every 2 to 3 weeks, to ensure that they recover or, as I said, catch back on their original birth weight percentile by 1 to 2 months corrected age. In infant who are not recovering and there are no sign of systemic illness, for example, any urinary tract infection or anything else, protein status should be closely monitored and evaluated, and supplementation should be instituted. I think that's the end of my presentation.
Thank you so much, sir. It was a very informative and very precise. Now we are going to take questions of participants. If you have any questions, you can ask easily. Online, raise hand, and participants in front can ask questions. Thank you so much.
Dr. Asad, please ask question. Dr. Asad Makbul.
Assalamu alaikum, sir. Really nice presentation. And, hope you get well soon, inshallah. Sir, my question was with regard to alkaline phosphatase and phosphate. When should we advise this? Should we have an X-ray beforehand, or if there is Sir.
So, can you hear me?
Yes, sir.
So, I mean, when we are discharging these babies, I mean, there are several studies. I mean, and there is established guidelines. When we are discharging these babies, we also look at their bone status before discharge and find out what's the amount of protein, alkaline phosphatase, and all that. So what we normally do in our unit, that we do the bone profile in very preterms on weekly basis, and depending on those profiles, we add those nutrients. When you are discharging those babies, then again we discharge those babies on supplements like multivitamins, iron, and these multivitamins contain, as I showed you in the presentation, the vitamin A, B, E, and C. All these vitamins are added to these babies when they are discharging. So while in hospital, and then when they are going home, we continue those supplements.
Thank you, sir. Sir, I would also like to ask a couple of other questions regarding I use the Fenton charts, and you mentioned the intergrowth 21 charts. How do they compare, and why do you prefer the intergrowth charts?
So let me just give you an idea about the intergrowth. I mean, these Fenton charts, I think it's from, if I'm not mistaken, it's from Canada. Is it? These Fenton charts, they are from Canada. Am I right?
Yes, sir. They are from.
Yeah. So intergrowth has been started basically as a flagship study which is done by the Oxford people, and fortunately we are the part of that. So intergrowth basically compared healthy mothers and healthy babies from 29 countries in the world. They looked at the healthy mother babies, their weight and height. I mean, these mothers can be from Pakistan, India, Mexico, Brazil. As far as Fenton charts are concerned, they reflect the local population. And what I'm trying to say is that could not be what I'm trying to say is that, I mean, if you're looking at one specific population, like the Canadian population, that probably is not the true estimate of the global population. So if you look at intergrowth, it will give you precise, in-depth detail that what are we expecting from an Asian mother or a Latin American mother. So that's why these intergrowth 21st chart have established, and we are using them in our unit for all very low birth weight infants.
Correct, sir. Jazakallah, sir. Sir, one last question, if you could allow, sir. You mentioned 100 kilocalories per 100 ml preterm formula. The only one that I know of is Pediasure. That approximates that one.
Now, as I said, I mean, during my presentation, that there is no clear guideline. I showed you the EBSCON guideline as well. I mean, on a appropriate gestation or inappropriate, or who's falling away or faltering from the centile. People have used human milk fortifiers, high calories formulas, whatever is available in your local population. You can use that. I cannot say for certain that 100 kilocalorie formula would be absolutely beneficial for this baby. I think you just got to follow that child and do according to the whatever the baby is showing you in terms of his head circumference, his height, his weight. And you rightly said that that's the only one. The other one would be in my mind, which is locally available, is from Nutri. It's called Nutrini, which has 1 kilocalorie per ml. But again, I'm not favoring any of the formulas or any of the concentration. What I'm saying is that follow that, whatever is available at your place, by just adding human milk fortifier. I mean, you can increase the calories. So it's all dependent on what sort of practice you are doing.
Thank you very much, sir. Thank you.
Fayaz, you can ask the question.
Hello. Assalamu alaikum, sir. Dr. Fayaz here. Thank you very much for the very nice and concise presentation. I want to ask the question regarding human milk fortification. So, in our part of the world, we have only one human milk fortifier available, that is from Nestle, and its stability is in question, that company state that after mixing it with the human mother human milk, we can use it for 4 hours. I want to know that is there any other preparation that can be kept for 24 hours or more than 4 hours? So because if the baby is 1 kg and his total feed is 20 ml 3 hourly, and we have to mix it in 25 ml per sachet at least, so we have to waste the remaining volume. So how can we counter that? So that was the confusion in our unit. I wanted to ask that. Can you guide us in that regard? Thank you.
So, Fayaz, there are two things. One is recommendation from themselves, the Nestle one, that you should not add human milk fortifier until the baby is on 100 ml per kg per day. Now, unfortunately, as you're saying that if the baby, let's say if the baby is on 11 ml, and you have to mix that in one sachet in 25 ml, so you end up losing half of the sachet. So if you're losing half of the sachet, I mean, there's a thing which we need to sit and speak to the Nestle people. If instead of giving this, sachet, if you can split this into 4 with the packing coming from the Nestle, then we probably can add in the lesser amount as well. I am not sure if they have done a study mixing human milk fortifier below 100 ml per kg per day. But again, that's for the future to evaluate. That solution would be, as you said, that if they can further divide it into 4, then we can start putting human milk fortifier. 25 divided by 4 is like 7.5 or whatever. We can add 1 mini sachet to this amount of milk. But that's just, out of the box thinking. Whether it is recommended or it is not recommended below 100 ml per kg, I'm not sure.
Thank you very much, sir.
Okay, any other question? So,
Dr. Sabha is here. Dr. Sabha, please, you can ask questions.
Dr. Rehan, I'm Dr. Sabha from Indus Hospital. I had 2 very quick questions. One was that regarding vitamin D deficiency in preterm. So the literature which I've read, I may be wrong, but there was recommendation to start vitamin D supplementation at 6 weeks for preterm and 8 weeks for term infants. So is that correct? Or what you mentioned was that at 8 weeks we start for all? I want clarification on that.
Yes, Dr. Sabha, we do start vitamin D supplementation as soon as the baby is on full feed.
Okay, so
And
second
these
question
are
was that, please go ahead. Sorry.
These are the ABSCON recommendations which I've showed you in my presentation.
Okay, so one, I was going through literature and I found studies which stated that if we supplement mothers with vitamin D who are lactating, that it also improves the vitamin D status of their newborns. So do you have, in your experience, have you encountered this? Practice this?
it means that if the mother is breastfeeding, then that will improve the status on the baby?
No, what I mean is that if the
Is-
mother, if the lactating mother, we supplement vitamin D to the lactating mother in addition to vitamin D supplementation to the baby. So literature says it improves overall status. In your experience, have you practiced this?
I think there is no, in terms of there is no RCT, which I can say that, you know, supplementing mother during pregnancy or during lactation would improve. But I think that's, my answer to you would be then definitely if we are giving vitamin D and the mother vitamin D level is normal, then that should help the baby and putting more vitamin D into this baby during lactation. That is my understanding, that it should improve vitamin D status on the baby.
Because you know, we have admissions because we see that, you know, the children after the newborn period. So in vitamin D deficient mothers, I cross-checked with mothers' vitamin D levels, and surprisingly, not surprising, in fact, we expected that all the mothers were severely deficient in vitamin D. So it kept on me thinking that if the mothers are so deficient in vitamin D, their breast milk will also be deficient also. So
A short vitamin D supplementation. There's a place called Bethnal Green in London. And this Bethnal Green is an area where there is lots of Bengali population lives over there. And then when we were in UCL, we have started observing that all of these preterm or the term babies, they are presenting with these hypocalcemia and some jitteriness and all that. So we have started looking at the possible causes. And we found out that these babies are specifically came from this Bethnal Green area. Following that, I don't know, I mean, this is strange, but what the local council have taken an initiative that they have started putting vitamin D in the tap water, wherever each house is getting a tap water, they have started putting vitamin D into this tap water. And when they have looked at their level at 6 months in time, I mean, all these mothers are vitamin D sufficient. Now, just to keep one thing in mind, that vitamin D is a fat-soluble vitamin. So I don't know what's the implication of putting vitamin D into that tap water, and did it really absorb, or that's for you? But that's one way of looking at it. That, as I agree with you, that if we supplement the mother, that will definitely help the baby.
and I think it's a good opportunity to share this information on this platform with all the other physicians that formally government has fortified food, 2 food products recently, which are also available in market. So one is Sunrich Atta, which is fortified with vitamin A, D, and zinc. And the other is cooking oil. So they have fortified different cooking oils, and to mark it, there has a symbol of handi on it. So if you see an oil with symbol of handi, it means that this oil is fortified. So we can advise the mothers and other people also to use these fortified atta and oil.
That is good. Very good.
Okay, thank you. No more questions.
Any other question?
Naseem, you can ask question. Dr. Naseem. Naseem, you can unmute your file and you can ask question, Naseem. Naseem Abbas, can you hear me?
Okay, if there is no more question, then I think we should leave, and I'll say goodbye to everybody, and I hope this will give you some insight when we are discharging these preterm babies. Probably this lecture will help in organizing things.
So Naila wants to ask a question. Naila Nizam.
Assalamualaikum, sir.
Salam.
So thank you. It was a very nice presentation. I have a query. These intergrowth charts, are they you're using it as a soft copy, or you're having their hard copies to monitor the growth?
And we are using intergrowth we are printing it out and using it as a soft copy in babies. I mean, we are also in a process के किसी तरह हम उसको जो है अपने HIMS system पे डाल के और उसको follow करते रहें. So whenever we need to look back and look at the centiles on this baby, then it should be available as well. But for the moment, we are using it on a hard copy.
Okay, sir. So that is something I want to request, that it should be present in HMIS, because rest of the data is there, and just this growth, we have to do it on a hard copy. And if I keep it with me, I usually miss it, and if I give them to the patient, they never bring it back. So it was my request.
That's what we are trying aiming for.
Okay, sir. Thank you, sir.
Thank you very much, sir. Thank you. Thank you, participants, for the precious time.
Thank you.